Hello, medical students. So a common concern is I finished all the NBMEs and my score still isn't where it needs to be. I wish there were more NBME questions. I'm going to explain to you everything you need to take away and have learned by the time that you finish NBME 26. I'm going to do it all on my infinite scroll pad here. So by the time we finish, all of this should be hopefully filled up. This takes a tremendous amount of effort and I'm doing this because I want you to succeed. So please consider liking and subscribing. Without further ado, the first question you need to fully understand, and I'll walk you through it. We got a 10-month-old boy. He's brought to the clinic with a 3-week history of chronic coughing and poor weight gain. He's had a lot of episodes of pneumonia, 1 hospitalization for otitis media. He's currently febrile and appears lethargic. Physical exam reveals decreased breath sounds in the right lower lung. Chest x-ray shows right lower lung consolidation. Flow cytometry reveals absence of CD19 B cells, but normal CD3. Serum protein demonstrates no peak. What is the most likely underlying defect? Now, what I need you to know at this point in your prep, after having finished NBME 26, is that the absence of a gamma globulin spike with recurrent infections and absent CD19, that's going to be a B cell, points you toward a diagnosis. And that's the diagnosis, Bruton's agammaglobulinemia. This is an X-linked disorder, and it's due to which? The BTK gene mutation. And what does this do? This is going to block your B cell maturation. And so on test day, you might see a graph that, looks like this. It's got some little you got your alpha, your beta stuff. What's going to happen is whenever we get to that gamma region, whenever we get there, it's going to be low. Gamma is going to be low. That's going to tell us that we're looking at BTK. The punchy, most critical facts that I need you to know about this for step 1 success is we have recurrent staph, no gamma spike, and so it's Bruton. Your buzzwords are going to be your recurrent bacterial infections because you don't have those opsonizing antibodies. And these infections are going to be catalase positive because they thrive without the Ig opsonization. And here's an interesting point. This is probably going to happen after about 6 months. The question stem I gave you guys, a little bit older. Why? Why 6 months? Because that's after the maternal IgG is waning, okay? So the mom's IgG is protecting the baby for about 6 months. And then, we're getting staph infections. We're getting catalase positive infections. What's going on? Our B cells are not maturing because of this broken BTK gene, Bruton agammaglobulinemia. Look for absent CD positive cells. You need to know this. Look at that. First concept done. Now, I'd love for you guys to get in the habit of not just getting the right answer, but knowing some potential trap answers as well. So I've put some trap answers below. Here are the key features, by the way. Absent B cells, normal T cells, but we got to get going. Class switching deficiency. You can see that on test day. It's going to be hyper IgM. Failure of the phagolysosome. That's Chidia-Kagashi. I heard from somebody on a recent 2025 test day. This is all hearsay, but this is a very high yield topic. Chidia-Kagashi. Albinism is a little bit too easy, so they probably won't give you albinism. What they probably will give you is giant granules or a phagolysosome dysfunction. Another trap answer they could give you is Thymic Plasia. Again, all this content is original. However, I've been in your shoes. I know what you need to know, especially at this point in your preparation if you've just finished your first NBME. And this is what you have to get down. So Thymic Plasia, what does that make you think of? First thing should definitely be DeGeorge, right? And then DeGeorge is associated with some buzzwords like low calcium and also absent thymic shadow. Now, this is going to be a little bit too easy for them, right? They have to make some medical students fail. And so they're going to have low CD4 T cell or a low T cell. And that should also low T4 T cell should make you think of an MHC. MHT class 2 defect, that's bare lymphocyte syndrome. And the reason it's not that is because in our question stem, our CD3 positive T cells are normal. So as you can see, it's not enough to just be recurrent infections, catalase positive, nailed it. No, we have to also distinguish between hyper IgM, Chidia-Kagashi, the albinism giant cells, Thymic Plasia, DeGeorge, knowing it's low calcium, and also low T cells, and then knowing also bare lymphocyte would have low CD4 positive. So it's a whole bunch of stuff. Okay, that is our first topic that we have to cover. Just to let this stick in your brain here, in this condition, you have 0 immunoglobulin levels, no B cells on flow, and a flatline gamma region. You have Staph aureus, you have H. flu that seals the deal. It's a B cell maturation failure. Learn it, love it, never miss it on test day. Okay, the next question that I need you to understand for step 1 success is going to be if you see self-mutilation and you see answer choices that look a lot like what you see up here. Conversion of adenosine, inosine, xanthine, uric acid. That should definitely cue you into the salvage pathways. So here's our practice question. 6-year-old boy, neurologist, makes you think of a little bit of Leach-Nyhan syndrome. He's got worsening behavioral disturbances, outbursts of aggression and biting his own lips and fingers. Physical exam shows spasticity. Got some elevated serum uric acid, which enzyme reaction is deficient. Okay, so you should be thinking of a diagnosis at this point. And what you need to understand is that we have ribose 5-phosphate up here. That's going to get converted into IMP. You guys have probably already seen this chart before, IMP, GMP, AMP. What we're doing here is explaining the salvage pathway for purines. So from IMP, and you don't really need to know too much of this, Don't get too into the weeds here. The most important thing you need to know is hypoxanthine is over here though. And the way the hypoxanthine gets back to IMP has to go through HGPRT. All right. And so if you have Lesch-Nyhan syndrome, then HGPRT is going to catalyze like this conversion of your xanthine to IMP, and also your guanine, by the way, which I'll just write over here. Your guanine is going to go to GMP. And so if you lose this salvage due to Lesch-Nyhan syndrome, then you get a buildup of uric acid. Why? You can't go back. And so you're just going to go this way so you get more uric acid. Then that accumulation causes these neurosymptoms. And that's why when I read the first little part of the question stem, I was like, oh, he's got neurosymptoms, uric acid buildup. Why? Because this hypoxanthine cannot be converted back to IMP because of this defect. What is this defect called? Lesch-Nyhan syndrome. Boom. That's how you answer this question. So students can get caught up in the weeds of like, oh my gosh, what's this? What's that? And like, fair enough. I mean, to answer this question, we kind of do need to generally know what inosine is like involved in this pathway. But more importantly, hypoxanthine is going to be involved in Lesch-Nyhan questions 9 out of 10 times. All right. So in this case, the correct answer is B, conversion of hypoxanthine to monophosphate. All right, so some trap answers. Adenosine. Now, I know why they're saying that, because over here we have adenosine. It's just chilling. And adenosine does actually go over to inosine, right? That's cool, but that's a different deficiency. That's the buzzword you should be thinking of is SCID, down on SCID. That would not have behavioral components. That's your adenosine deaminase. And that should make sense, right? Because we're going adenosine deaminating and then we get the inosine. So that's SCID, down on SCID row, different presentation. No neurosymptoms. Xanthine to uric acid. There's this little step that I skipped here, but that's right here. Because if you zoom in, man, if you guys just would have paid attention, you'd see, I knew that I wrote this. Boom, there it was there the whole time. That's the intermediate step between hypoxanthine and xanthine, right? That's what guanine is going to plug into, right? And so if you guys would have just paid attention when I drew that, you would know that xanthine to uric acid requires xanthine oxidase, right? What do you guys know about xanthine oxidase? Well, it's super important and high yield. That's why I drew it so big, is that's the target of an awesome drug called allopurinol. And so what we need to know about allopurinol is going to be over here on the side. Don't you just love how I've done this? Allopurinol blocks xanthine oxidase. So if you block xanthine oxidase, then you get decreased uric acid, and that's going to cause gouty buildup. Or rather, uric acid is caused by gouty buildup, and so this is used for gouty buildup. So you got the gout, what do you give them allopurinol so you get less uric acid? Here, we got a different condition, don't we? Here we have too much uric acid, it's causing neurosymptoms in our kiddo. Associations would be like tumor lysis syndrome prophylactically used there. In Lesch-Nyhan syndrome, you can treat hyperuricemia, but not the neurosymptoms. Okay, very important. Very, very important. 6-MP, that has like 2 letters, and I always think of xanthine oxidase as XO. So XO has an interaction with your MP. And then azathioprine, that one just reminds me of like uric acid stuff, and so that's how I remember that one. Okay, there's the pathophys if you want it. Here's a sub-practice question, but we got to keep moving, guys. Basically, for your quick aside, if a patient's got gout and they suddenly develop pancytopenia after they start, it's because allopurinol blocks xanthine oxidase. And we talked about that. And xanthine oxidase inactivates, and then you get toxic levels of 6-MP because that reduced metabolism. Boom, another question. Look at that, guys. The concept map is filling up. Again, these are not NBME 26 questions. They're just the content that I believe you need to know, according to my own judgment and estimation. With that being said, let's move on to the third topic I really want you to master. So in my own practice question here, a 28-year-old male construction worker is brought to the emergency department. He's been trapped under debris for 6 hours. Severe leg pain, right calf is tense and tender. Oliguria, dark reddish brown. Boom, right there, reddish brown urine. What does that make you think of? This question's over as far as I'm concerned. It's acute tubular necrosis. C. Elevated creatine kinase, that's perfect. They don't even have to tell us that much. They probably won't on test day. This is going to be rhabdomyolysis, guys. Prolonged muscle compression. Okay, this releases myoglobin. That's nephrotoxic, and that causes your tubular necrosis. So we got a tubular fracture. That should make us think of a compartment syndrome, which makes us think of rhabdo. We get myoglobin-induced ATN. Buzzwords, it's out of proportion. Peroneal nerve involvement could cause paresthesia between your first and second toe. Dark urine, though, is the big thing that I want you to think about. So myoglobinuria, red urine. No red blood cells. Super important point. No RBCs. All right, so ATN is going to be caused there. That's why our correct answer is going to be C. We need IV fluids. There's a risk of arrhythmias, kidney injury, and also DIC, elevated creatine kinase, elevated potassium, elevated phosphate, decreased calcium. So we got that breakdown happening. All right, trap answers, why they're wrong. Diffuse proliferative glomerulonephritis. So diffuse proliferative, that's when you have an immune complex type 3 deposition there. So that's diffuse. So minimal change disease, you should always be thinking of a child. This is also nephrotic syndrome. So crazy answer if you chose that. This nephropathy, you're thick boy. Okay, so that's membranous nephropathy. Basement membrane, you got the spikes. That is also nephrotic, not AKI. Interstitial nephritis. So interstitial nephritis, see that rash in the eosinophils and recent drug exposure. Picture this for this third concept that I need you to nail down. Trauma patient's got a fractured leg, intense pain, and red urine that has no erythrocytes. It's going to be myoglobin. So myoglobin is going to clog all the tubes up and it's going to cause injury. So if you see like a crush injury, tibial fracture, rhabdomyolysis, ATN, that's what you should be thinking of. Interstitial nephritis, more of the rash. Third concept down. On to our next topic. So we have a full-term neonate, and he's got some large blisters on his hands and feet within hours of routine handling. There's no family history of similar findings. The skin biopsy shows subepidermal blistering. You also see some linear deposits of IgG. And where do you see this? On the dermal-epidermal junction. So which protein is targeted? Our answer is going to be B, type 7 collagen. All right, so there's this thing called your anchoring the fibrils between your epidermis and your dermis. So imagine what we got here is epithelium. Cool. Nice. Well, that would make these guys right here your integrins, which would make this guy right here your basement membrane. Nice. So here we got a little blood vessel, got some little erythrocytes going on, a little bit of blood of action here. Now, this child in our question stem has epidermolysis bullosa acquisita. It's due to the target the 7 collagen. Now, epidermolysis bullosa, it's when you have antibodies that are targeting these anchoring fibrils. And this would include your hemidesmosomes. And what I want you to think about, I have another video about this, but hemidesmosome starts with H, right? Hemidesmosome. And so I like to think of these guys, hemidesmosomes, as like anchoring this part and this part right here. They are anchoring the epidermis and the dermis, right? That's how you remember it because it's H. So imagine we got an epi and a dermis and it's linking them, okay? So those are going to be your anchoring fibrils. And then this kid has epidermolysis bullosa. And so it targets that 7 collagen. So it'll disrupt that H, right? The hemidesmosomes are going to be disrupted because that's a type 7 collagen. Now, how do we know this is a blistering disorder, right? And our question told us that the baby's getting some blisters. And so these anchoring fibrils are composed of this type 7 collagen. And so you get the blisters at that junction. How do you know it's at the junction? Well, like I told you, 8. Hemidesmosomes, you know that they're type 7, and then you see epi and then derma, and you know it connects. So these are the anchoring fibrils, so it's the hemidesmosomes. And then you think, okay, well, they didn't even ask you this, but this disorder is going to be epidermolysis. Blistering tells you got the anchoring fibrils, then you know that it's at that junction. And so you know it's the type 7, and you know the condition. That's the way that you map this. Okay, especially with Crohn's disease, lupus, genetic mutation of type 7, presents at birth or infancy, risk of infection. All right, so desmoglein, that should make you think of pemphigus. That's the superficial blisters. Okay. Type 4, Alport good pasture. That's glomerular. This is 7. Ecadherin, lobular breast carcinoma. There's going to be atopic dermatitis involved in the skin barrier. These guys with this condition are so gentle that even swaddling will lead to blistering. That's because those type 7, the anchoring fibers like the hemidesmosomes are broken in these babies. Now, some of you guys are like, oh, collagen type 7, how'd you know? Well, check it out. 1 is the bone. Notice that it has 1 in it. 2 is cartilage. Look at that. It's cartilage. I love this. I love this one, guys. This is so good. Like and sub if you like this stuff, Ticulin. So your vessels, uterus, granulation tissues. You think pliability for 3. Number 4 is the floor, right? Glomerular basement membrane. And we'll skip over here to 7. So 7 goes to heaven. So there we have the dermal epidermal linking, and that's the hemidesmosomes, so you go to heaven. H for heaven. I also have a PEG system, mnemonic system that I'll teach you in another YouTube video that helps you crush your CDs, but like it's up for that. It's coming soon. Associations, 1, osteogenesis imperfecta. Type 3, another way you can think of this, well, 3 words, vascular, Ehlers, Danlos, boom, boom, boom. Fragile vessels, aneurysms, pliability. Floor on the floor, 7 in heaven. There you go, guys. So many freaking points from this video. This is what I believe you need to know after finishing your first test. I'm proud of you guys. Way to be. You guys really just went out there and you just clicked a video to study because you're trying to be a doctor, because you're trying to help other people, ostensibly. That's awesome. Give yourself a pat on the back. Go do like 5 push-ups. Did you do 5 push-ups? Cool, now answer this question. 5-year-old boy, recurrent infections, minimal trauma, blue sclera, hearing loss, osteogenesis imperfecta. That was easy, wasn't it? Next question I need you guys to know. Welcome back. You're looking muscular now. 58-year-old man has progressive abdominal distension. I'm just thinking of like some people eating potato chips like, oh, thanks, man. Anyways, fatigue, ankle swelling, CDs, hepatomegaly, elevated JV. Boom, that's huge. JVP. It's elevated. So what's the diagnosis? Constrictive pericarditis. That's the answer. So elevated JVP with the CDs and normal liver dysfunction points away from cirrhosis. Another big thing on this question stem is that they tell you that they have septal bounce. So like electrical alterns, like the heart is like swinging over. This is just a little bit different than cirrhosis, right? This is constrictive pericarditis. So you get like the, kind of like the 4 chambers of the heart are going to be swelling, kind of equivalent in their pressure. And this could be because of an infection. And so you have like a right heart backup. Cirrhosis is just a little bit different. We'll talk about that. So cirrhosis, JVP is not elevated unless there's cardiac involvement with cirrhosis. So restrictive cardiomyopathy, BNP would be elevated. Now, most students, when they see a CDs, they just think liver immediately, right? Well, not always, because if you have like a neck vein that's like popping out, specifically, you should think of constrictive pericarditis. That's why we measure that. on physical exam. So that's when you have like the right pericardial sac is like locking the heart in place. So that's a way that you can cause it's that constriction from pericarditis that causes that restriction and the ascites. So it's not always just, liver issue. For instance, Budd-Chiari syndrome, that's hepatic vein thrombosis, painful hepatomegaly, but JVP would not always be elevated. Right-sided MI, chest pain, and also the ECG was normal. So the takeaway, what I want you guys to know is that cirrhosis, the JVP is not always going to be elevated. However, in constricted pericarditis, it will be. That was easy, huh? Now, we said something interesting about BMP. We need to know this. It's high yield. Why is BMP elevated in constricted pericarditis? Well, if we have a restrictive cardiomyopathy, then we get brain natriuretic peptide that's released by the ventricular myocytes in response to the stretching. So you have systolic heart failure, restrictive cardiomyopathies, volume overload states. You have the stiff pericardium. It prevents that ventricle wall stretching. So less BMP is secreted despite right-sided syndromes. Stretch causes BMP. So in constricted pericarditis, you have fibrosis, and that prevents the expansion. So you inhibit the stretch, and that causes less BMP. So despite your volume overload signs, what do I mean by that? Well, I mean, you got JVD going, right? You got volume overload, but the BMP is not elevated. Well, it's going to be fibrosis because you're stretched out, so you have less BMP. And so if you see a BMP of like, less than 100, that's going to be like constricted pericarditis despite the heart failure symptoms. And that's going to be different than restrictive cardiomyopathy, right? In restrictive cardiomyopathy, you have increased BMP. So tangential other practice question, basically the BMP is going to be low in constricted pericarditis because of that fibrosis. And so the answer is A, reduced stretch due to pericardial constriction. So just watch out for that twist. Just want to go on that tiny tangent. And look at that, guys. You're learning it. You got it. Whoop. Let's talk about the jejunum. So remember DJ ileum, right? That's the order. And our jejunum is the site of nutrient absorption. That's where we get our proteins. Ileum, that's where we get our vitamin B12, also bile absorption. And also in the duodenum, we get our iron, also calcium and folate. All right. So if we lose our jejunum, then we have malabsorption of our carbs and our proteins. And one mechanism we have is increased surface area. So we got our villi, microvilli, rich blood supply. Why? Because this is the absorption center. And so we have these folds which increase the surface area there, and a long vas recta that ensures you got perfusion there. So quick practice question I need you guys to know. What distinguishes the jejunum? Well, all of those features we talked about, also absorption of simple sugars and amino acids. So carbs, proteins, absorption of B12, what do we say that was? Ileum. That's with your bile. So you can remember the I for ileum works with the I for bile. Now here's a horrible prejudiced way to remember B12. I think vegans and vegetarians have the upper hand. I truly do. In the ethical arguments against animal abuse, but sometimes you can be ill from one of those diets. And so, yeah, B12, ill, B12, and then bile, I for bile. Duodenum, iron fist, bro, iron, F, folate, calcium. So iron and calcium is going to be duodenum, absorption, boom, got it. Antigen presentation of the pair patches. So that's also going to be in the ileum, pair patches. That's part of your gut immune system. And alkalization of chyme in the Brunner glands, that's actually seen in the duodenum. So that's what I need you to know. The most high yield stuff for step 1 about GI absorption stuff. Cool beans, y'all. For my next trick, I want to teach you about CLL, chronic lymphocytic leukemia. What do you need to look out for with this? Well, spirocytes, that's a perfect circle, by the way. The easiest way is you think that C is a loser and he envies the B cells. So CLL is when you have malignant B cells that produce antibodies against what? The red blood cells. So this C is jealous of the B. He's a loser. And so he gives malignant B cells and these attack your red blood cells. CLL, some associations you could think of as like lupus, SLE, because that's like a chronic autoimmune disease and it causes warm autoimmune hemolytic anemia. And so our warm, we think of IgG, and then our cold, we think of IgM. And the way to remember this is that your M actually looks like a snowflake. If you look at it, it's like the pentamer one looks like kind of like a snowflake. So it's cold, complement mediated. So yeah, we just get our antibodies that bind the red blood surface, and then they're going to be destroyed in the spleen. So the spleen is a clean machine, and you get the extravascular hemolysis. And so the spleen causes those spirocytes to form. So you see an anemia with a positive red tick count, spirocytes in the smear, positive Coombs test, unconjugated bilirubin, decreased haptoglobin, because that's the product that clears off the broken down heme, and associated CLL, SLE, and lymphomas. So here's our practice question. 60-year-old woman with a history of lupus, erythematosus, presents with fatigue and mild jaundice, hemoglobin's at 7.2, so we got anemia, and spirocytes, and also the Coombs test is positive. Okay, so Coombs test is positive. So we're looking at warm autoimmune anemia. This is when we have our IgGs. We have the splenic destruction. Why? Because the C cells are losers. They envy the B cells, attack the red blood cells. And then our spleen has to compensate. So the spleen is a clean machine. Extravascular hemolysis takes place, causing this perfect circle. Increased retic count. We have IgG antibodies because of our AIHA. Boom, there it is. Increased unconjugated, increased retic count, decreased haptoglobin associated with lymphomas. That's that, folks. Okay, spirocytes, retic, Positive Coombs confirms diagnosis. Complement would be cold, bone marrow suppression, that'd be low retic count. Splenic sequestration causes pancytopenia. Mechanical destruction would be histiocytes. So you see, older patient immune system has started attacking its cells, spirocytes, elevated retic count. It's antibody-mediated destruction of their own red blood cells through CLL. Cool beans, guys. So let's talk about the direct Coombs test. Basically, red blood cells are coated with autoantibodies and complement. Cold is IgM, complement fixation, so mycoplasma, Epstein-Barr virus. Hemolytic disease in newborn, Rh incompatibility, so it's coated in IgG, transfusion reaction. So this is the year warm. So what happens is our red blood cells are coated with IgG. Direct Coombs test detects that coating, all right? So we can see that coating. That's what it is. Agglutination is a positive result. So think of the spirocytes, the warm. Practice question, warm anemia, autoimmune hemolytic. Hereditary spherocytosis, that'd be spirocytes, but the Coombs test is negative. Different mechanism. TTP, that's the schistiocytes, not spherocytes, and so you have a negative Coombs test. Aplastic anemia, pancytopenia, low retic count, not hemolysis. And G6PD, that's the bite in the Heinz bodies. Super high yield stuff. Look at that, guys. We're gragitating. That is a quote from Rick and Morty when they go to the Citadel. Amazing episode. Teacher, did I gragitate? All right, do another 10 push-ups. By this point, you guys are going to be gym bros by the time you finish your dedicated. So acute mitral regurg after an MI. So what I want you to think about mitral regurg is that you should suspect the papillary muscle or the chordae tendineae rupture. So here's our practice question. We got a man, dyspnea, hypotension, new holosystolic murmur at the apex, Swan-Ganz catheter, abrupt increase in left atrial pressure during the systole. So that should automatically heal us into the regurg. And the cause is going to be the chordae tendineae. So you have a sudden murmur after pulmonary edema and a rise. That's going to be acute mitral regurg. So this is like a mechanical failure. You have the crashing blood pressure, flash pulmonary edema, sudden murmurs. There's just damage there. It's not aortic stenosis. That would cause a systolic one, not VSD. That'd be a step up in the right ventricle, O2. Tamponade, equal diastolic pressures. Left ventricular aneurysm, that'd be paradoxical wall motion. And so the key facts here, the association I really want you to know is after an inferior myocardial infarction, you have the posterior medial papillary muscle ischemia and rheumatic disease. So infection, MI, then you get the papillary muscle or the chordae tendineae is damaged, and that's going to be leading to mitral regurgitation. Know the signs, and it's going to kind of squeeze out. The best way to think about this is you get your pumps of the heart, and I like to think of what's happening in each zone. So here's like the aortic, and here's your mitral. And so if it's closed in systole, because you have to close it in systole because you're pumping, you're like squeezing this. And so aortic stenosis would be like, ooh, trying to get out this aorta. And then mitral regurg is going to be during systole because this is going to be closed so that the blood can go out in this direction. And so it's not closing, so it's regurgitating. That's the way I like to think about these murmurs. It makes it super intuitive. There we go. Nicely done. We're cruising right along. So we got a 28-year-old man with a brain injury treated with intravenous mannitol. Now he's thirsty, signs of increased urine output. What explains the ADH response? It's going to be an increased plasma osmolality that's sensed by hypothalamic osmoreceptors. So what I need you guys to know is that mannitol increases plasma osmolality as sensed by the hypothalamic receptors are like, ooh, look at that osmolality. Let's trigger some ADH release. Antidiuretic. Why? Because we can get more water reabsorption. We can deal with that osmolality. That's why we get the ADH response in this question. Because mannitol increases the plasma osmolality. That's what it does. And boom, it's that simple. So the plasma osmolality increases, and what do we do with the ADH to compensate? Increase. High yield on step 1 is homeostasis, right? So you have mechanisms of tissue growth, hyperplasia, for instance, increasing the number. The body responds, right? And so what is the body going to do if we have increased osmolality? Well, we're going to increase the ADH. And what's going to do that? Well, this is in the hypothalamus, where we can cause these things to happen. And so it's going to be a receptor there. Boom, increase ADH. So you can logic through a lot of these things like that. So osmotic gradient sensed by baroreceptors. Why is that the wrong answer? Well, baroreceptors, these guys are like the volume pressure sensors, right? So this is not osmolality sensors. Decreased blood volume by the juxtaglomerular cells. Anytime you see juxtaglomerular cells, I want you to think of like the RAS system. And so that's just a different system going on here. So not quite. Decreased oncotic from albuminemia. So low albumin is what they're saying here. And if you have low albumin, then the body's going to go out to try to find some albumin, and that's going to be like edema by definition. And so that's not it. Here we're talking about like ADH stuff. So CNS inhibition of posterior pituitary. Well, if you're inhibiting the posterior pituitary, then that would inhibit the ADH. So no. Opposite response. So mannitol sucks off all the water from the cells like a sponge. It's just going to take them all away. Or rather, here are the cells, and it's going to take them, increase the osmolality is what it does. That's what I'm trying to say. So you give a mannitol, it increases the osmolality, so then the hypothalamus responds ADH. That's the mechanism. That's all we need to know. And these are osmoreceptors, not baroreceptors. Now, what I want you guys to know is if you see raw shellfish and jaundice, you should just automatically be thinking of Hep A. This is a self-limited fecal oral transmitted liver virus. The diagnostic clue, anti-HAV, IgM. IgM stands for the thing you make if you have the sickness, and that's the reason. Especially in developing countries, it enters the GI tract, reaches the liver portal vein. The CD8 T cells and natural killers start to kill you. The body is just stupid. Intelligent design. That's just kind of like a funny concept for anybody who knows evolutionary biology. That was my major at Harvard. And honestly, after taking my 20th credit in that specific discipline, I feel like I could never see the world the same. Okay, well, that's neither here nor there. Well, I guess it is. Because you have to know that the body is stupid, and it goes CD8 positive T cells, natural killer cells. And it's like, oh, hey, you're chilling over there in the GI tract? Let me just kill you. Or excuse me, I said the GI tract. That's where it enters in, and then it goes to the hepatocytes. And so literally your body with CD8 positive T cells, natural killer goes, hey, you guys chilling in the hepatocytes? I'm going to just kill you. Speaking not necessarily to the virus, but speaking to the hepatocytes. So let's just kill ourselves. I mean, I guess it is self-limiting, so good job, body. But the damage actually comes from itself. You know, it's kind of like getting a sword and just slicing up your liver because there's an intruder there. That's what the body's doing. Good job, body. I wish I could optimize the software that my body runs on. Enough said. So this is going to be a non-enveloped SS RNA virus. New video coming out explaining how you can remember all of those. 2 to 6 weeks in incubation period. And then you're going to increase, it's transaminitis, right? So you're increasing your AST, ALT, and also you get the bilirubin. Here's our practice question. Let's see if we know this. Again, this is pass level. Need to know by the time you finish your first review for your first NBME. 33-year-old woman, returns from Asia, all this stuff, yelling at the eyes, elevated LT, all that stuff. What describes the virus? Non-enveloped, causing acute self-limited. That's definitely a HIV. Enveloped DNA virus. So here are the trap answers. HBV is enveloped, causing chronic problems. Rio, double-stranded RNA. Retro, integrates host genome, not tropic. It's like HIV. Myco causes granulomatous hepatitis, not acute. So the A in hepatitis A, you can think stands for acute. You know, this is just going to be like 2 weeks later. Whereas HBV and HCV can become chronic. Blood transmitted. Also bedroom transmitted. It was actually, yeah, so just different mechanisms of transmission that we need to know. Next thing is mycobacterial infections cause granulomatous inflammation. What is a mycobacterium? Well, it's the genus of 190 species, causes serious infections in us mammals. So we get the granulomas in the liver. Casein granulomas is classic for Mycobacterium tuberculosis. Here's our practice question about it. So if we have an immunocompromised person, the MAC is going to disseminate and involve the liver. So granulomatous hepatitis with AFB positive bacilli is going to confirm the diagnosis for mycobacterial. HAV, that's an acute hepatocellular injury, as we talked about. Epstein's Barr, that'll raise your LFTs, but not like cause granulomas. There's our correct answer. Cytomegalovirus, that would cause intranuclear inclusions. E is non-granulomatous and also acute, kind of like Hep A. It's also a fecal oral route transmission. All right, so I think I'm going to make this part of a series. So like and subscribe if you liked this type of video. I'll be filling out the rest of these, and together we're going to finish every single concept you need to know by the time you finish your first NBME exam. And most students start with NBME 26, and then they go on and they do 27, 28, you know. And if you really want to support what we're doing here, give me a subscribe. By the way, I programmed the lights over there to play tic-tac-toe, but I'm going to add channel membership so you guys can determine whatever shows up on my LED lights. I'm pumped. Oh, last thing. Before you guys do a bunch of push-ups. I don't know what you guys are going to do after this. If you guys like and subscribe, then we're going to enter you into a free giveaway for our UWorld AI. What we're building is an AI-based platform that basically tells you all of your weaknesses. So it kind of does like something similar to what we did here, but it will auto-identify your weaknesses, and it will tailor-make practice questions that are extremely high quality. For you, they're going to be step-related, and also there are tons of AI tools that I've implemented, which you can see on my channel. So I studied computer science as a minor at Harvard, and one of my life passions is to give extremely high quality medical care and also educational tools to people all across the world. And I think that AI is a great way to do that. And so I'm building all these websites in my abundant spare time because I really believe in the power of artificial intelligence and empowering our next generation of physicians. So please like and subscribe. It really helps out. And a final incentive for those of you guys who stuck around for the end, please leave a comment. We want to keep the comments to likes ratio similar. And if you guys subscribe or leave a comment, I've actually programmed this onto my LED lights, and it'll happen like randomly when I'm here. So that's kind of fun, right? Anyways, this is like hook up to a whole bunch of other things that I'm doing. So you'll see it in the background. If somebody like subscribes, it'll be like, boom, kind of fun, kind of quirky. Hopefully you like what we're doing here. I really want to just keep improving this channel. Okay, enough said. Hopefully you guys have a great rest of your day. Take it easy on yourself too, and dedicated. You are doing so great. You're going to pass this test. You're going to be a doctor. The matriculation rates are like so high through medical school. It just feels like it sucks your soul, and it kind of does. And we can be a part of that solution together. So if you're into that kind of stuff, like and subscribe. We'll see you in the next one.